వస్తున్నట్లు షేర్ చేసినప్పుడు ఇది ఎట్లా అవుతుందా ఎందుకలా ఇట్లా ఇంటికి వస్తున్నట్లు షేర్ చేసినప్పుడు ఓకే
కామెంట్స్ ఇక్కడ కనిపిస్తాయా? Good afternoon, everybody. I'm Dr. Pranitha, consultant neonatologist, Cuddles. Today in this session, let's discuss about some commonly asked OSCEs in Neurosonogram for fellowship exams. So coming to the first question, which of the following is a normal finding in a 20-week fetal brain ultrasound? Absent corpus callosum, presence of cavum septum pellucidum, enlarged cisterna magna, abnormal cerebellum with a small vermis. So the presence of cavum septum pellucidum is a normal finding. So cavum septum pellucidum is a CSF fluid-filled space within the two membranes of septum pellucidum. So it is a normal finding, especially seen within the second and third trimesters. And sometimes it can be seen in the premature babies. Usually it closes within the first few months, and it is only present in 15% of adults. So let's see the common views in the NSG. This is the coronal section showing the 6 coronal views. So we keep the probe either 5 to 10 frequency hertz with the probe marker facing laterally, and we sweep from anterior to posteriorly. In the first view, we see the frontal lobes, the interhemispheric fissure, the bone, skull bone, along with the orbital ridge. And if we sweep slightly backward, then the sylvian fissure starts appearing. The lateral ventricles just start appearing. Here again, we see the frontal lobes and the interhemispheric fissure. This is the temporal lobe. Now, if we sweep slightly backwards, the ventricles are more prominent. So this is the most common view seen for the IVH. Here is the interhemispheric fissure, the frontal lobes. The two slit-like white spaces is the corpus callosum. Just beneath the corpus callosum is the cavum septum pellucidum we just discussed. And the ventricles are usually seen as a slit-like spaces. Usually they are much more prominent in premature babies compared to term babies. Just beneath the ventricles is the basal ganglia with the head of caudate nucleus, putamen, and globus pallidum. So these ring-shaped structures are the temporal lobes. Now, if we sweep slightly backwards, we see most of the things which we have seen in the previous view with the interhemispheric fissure, the frontal lobe, corpus callosum, lateral ventricles, cavum septum pellucidum, and just beneath it, now the third ventricle starts appearing. We also see the basal ganglia, and the tree-shaped structure beneath it is the brainstem, and here is the temporal lobe with the hippocampus. If we sweep slightly backwards, now we can still see the interhemispheric fissure with the frontal lobe. Parietal lobe is now more prominent. And then there is some white matter, which is showing the periventricular brush. And the choroid plexus starts appearing here. So here the white matter is compared with the choroid plexus to do the grading of PVL. This is the last coronal view, which shows parietal cortex along with the white matter forming the periventricular blush and the interhemispheric fissure. Now coming to the next question. What is the view? Identify the abnormality and the significance of this. So this is the fifth coronal view in which we are seeing the choroid plexus. There is a tiny cystic structure within the choroid plexus. So this is the choroid plexus cyst. Mostly it is a normal finding, but it is especially abnormal if it is if the size is more than 1 centimeter, if it is bilateral, as it is a soft marker for dysmorphism. If it is especially present along with other soft markers of dysmorphism, then it has to be considered significant. So choroid plexus cyst is not a true cyst. There is no epithelial lining. It's only spaces filled within the choroid plexus, which is filled with the CSF. Most of them usually resolve by 28 weeks of gestation. Since it is a soft marker for aneuploidy, we need to look for other signs of dysmorphism and other soft markers for aneuploidy, especially the size is more than 1 centimeter. They are bilateral and multiple. So coming to the sagittal views, here the probe marker will be facing anteriorly and we sweep laterally. So the most midline one is the midline sagittal view, then the little right and left sagittal views, and most lateral sagittal views. In the midline sagittal view, we see two whitish slit-like membranes. These are the corpus callosum. Just beneath the corpus callosum, we have a guitar-shaped structure, which is formed by the cerebellum. And just before the cerebellum is the fourth ventricle. And anterior to the fourth ventricle is the brainstem with the midbrain pons and medulla. So this is the frontal cortex, this is the parietal cortex, and this is the occipital lobe. If you go slightly laterally, here we will be able to see the ventricles. Just beneath the wall of the ventricles, there is caudate nucleus and the thalamus. So this is the caudothalamic groove, which is a highly vascular structure. And this is the origin for the germinal matrix hemorrhages. This white-shaped structure is the choroid plexus. And if we go more laterally, we'll be able to see the sylvian fissure. Along with it, we'll be able to see the lobes, the frontal lobe, parietal lobe, and the occipital lobe. So next, let's go to the next question. So we'll be usually asked to identify the views and then the diagnosis. So can anyone tell what is the diagnosis? So the diagnosis is IVH, intraventricular hemorrhage. So since there is no dilatation and since it is more than 10%, this falls into grade 2 of IVH. So what are the grading systems? Name the grading systems. Volpe and papillae are the grading systems. So which surrounding structure can you get confused with for IVH? As we have discussed in the previous sagittal view, since the choroid plexus is also originating at the same place, sometimes we can get confused with the choroid plexus for IVH. And what is the best antenatal intervention to prevent this condition? So antenatal steroids are the best intervention to prevent IVH. So let's go to the next one. Identify the diagnosis and the grade of IVH. You can type in the chat box. So this is grade 3 IVH. There is also dilatation of ventricles. So this falls under grade 3 of IVH. So presence of blood within the ventricles with dilatation of lateral ventricles falls under grade 3. And next, IVH with parenchymal involvement falls under which grade of IVH? So this is grade 4. We can see a fan-shaped hemorrhage. So grade 4 is like the most severe version of grade 1, and grade 3 is like the more severe version of grade 2. So coming to the next one, which grade of IVH is this? So this is grade 1 IVH. So coming to the classification, according to the Volpe's classification, there are 3 grades of IVH. Grade 1 is germinal matrix hemorrhage with little or no or minimal IVH, that is less than 10% of ventricular area. Grade 2 is between 10 to 50%, and grade 3 is more than 50%. And PVHI is taken as a separate entity in this. Coming to Papilla's grading of IVH. So grade 1 is small IVH confined to the germinal matrix, which is not causing much effect on the parenchyma. In grade 2, there is little amount of blood which is leaking into the ventricles, but there is still no ventricular dilatation. In grade 3, there is ventricular dilatation because of large amount of blood leak. And in grade 4, there is large hemorrhage into the germinal matrix along with the evidence of venous infarction. Coming to the screening protocol for cranial ultrasounds in preterm infants, in babies less than 28 weeks or babies less than 1 kilo, and in babies between 28 to 31 weeks plus 6, along with birth weight less than 1500 grams who are requiring life support, the first NSG has to be done within the first 6 hours of life. And later we do between day 3 to 1 week, day 3, day 7, day 14, and day 28. This is to rule out IVH. Then again, it is done around 32 weeks and between term gestation, that is 37 to 40 weeks, to diagnose PVL. But if the baby is 28 to 31 weeks plus 6 or 1000 to 1500 grams without needing life support, then we can perform the first NSG little late between day 3 to 1 week, and then again at day 28 and at term equivalent. In much bigger babies, 32 to 34 weekers, but having risk factors like twin babies, MCDA twins, and babies with microcephaly, babies requiring high ventilator support, surfactant, fetal distress, asphyxia, acidosis, low Apgars, hypotension. In these babies, there are no clear-cut protocols, but it can be done day 3 to 1 week as indicated. So let's see the prognosis based on the IVH. The prognosis is much better for IVH between grade 1 and grade 2. They usually resolve without much poor outcomes. In grade 2 IVH, there can be hydrocephalus or ventricular dilatation in 5% of cases. But coming to grade 3 IVH, hydrocephalus is seen in almost 20 to 40% of cases, mortality in 10 to 20% of cases, and neurodevelopmental sequelae are seen in 30 to 40% of cases. Whereas in grade 4 or IVH with the PVHI, the risk of hydrocephalus is much higher, 80%. The mortality is also seen in almost half of these babies, 50 to 80%. And neurodevelopmental sequelae are also seen in almost all of the babies, 80 to 90% of cases. So coming to the next question, what is measured here? So how do we calculate this? And what is the drawback of this measurement? So Levin's index is measured here, ventricular index. So we calculate it from the distance between the falx and the lateral wall of the anterior horn of lateral ventricle. So this is calculated in the third coronal plane. So the drawback is sometimes the values are not very clearly established in premature babies, and it may not go up very high in the early stages of hydrocephalus. So ventriculomegaly, we divide it based on the anything less than 5 mm is normal, but anything between 5 to 10 mm is graded as mild, 10 to 15 as moderate, and more than 15 as severe. So in the third coronal plane, we calculate the distance between the two frontal horns, the maximum distance, and divide it by 2. So we have this graphs based on the Levin index where the gestational age is taken in the x-axis and the ventricular index in the y-axis. So anything more than 11 mm is taken as abnormal for premature babies. But if you take age-specific cutoffs, for 28 weeks, anything above 10 is abnormal. For 30 weeks, above 10.5. And after 30 weeks, for every 1 week of gestation, it increases by 0.5 mm. Or anything more than 4 mm above the 97th centile is also taken as abnormal. So 4 mm above the 97th centile is taken as action line. So coming to the next question, what are the other indices to measure ventriculomegaly? So how do you measure them and what are the normal limits? So this is again calculated in the third coronal plane, the anterior horn width. So it's anything below 3 mm is normal. So 1 mm above the 97th centile or anything above 4 mm is taken as abnormal. So what is calculated here and what are the normal limits? So here this is taken in the fourth plane, fourth coronal plane. The third ventricle, it may not be visible in all of the cases, but it is especially seen in cases of hydrocephalus. So the third ventricular index is taken. Again, anything below 3 mm is normal. Anything above 3 mm or 1 mm above the 97th centile is taken as abnormal. So what is measured here? And again, what are the normal cutoffs? So here we are measuring the thalamo-occipital distance. So this is taken in the sagittal views, right and left sagittal views. So we are going to take distance between the thalamus posterior end and the anterior end of the occiput. So anything above 26 mm is abnormal or 1 mm above the 97th centile is again taken as abnormal. So for post-hemorrhagic ventricular dilatation, we have discussed regarding the 4 indices: the ventricular index, the anterior horn width, thalamo-occipital distance, and third ventricular width. So now let's proceed to the next question. So what are the views and what is the diagnosis? So here we see sagittal view, the most lateral sagittal view, and this is the coronal view. The diagnosis is periventricular leukomalacia. So this is grade 4 since it is extending into the deeper white matter and we see multiple cysts. So if we see periventricular cystic lesions which are extending into the periventricular region, it falls under which grade? So that is grade 2. And what are the causes of PVL? So causes of PVL are sometimes it can be idiopathic without any known cause. Can be secondary to prematurity, hypoxia, acidosis, asphyxia, sepsis, chorioamnitis, PDA. So what are the complications of PVL? Spastic diplegia is the most known complication of PVL. Apart from that, there can be some intellectual problems and visual disturbances. So grading of PVL, there are 4 grades. The first grade is transient periventricular echo densities, which are persisting for more than 7 days. So in premature babies, anything periventricular echo density within the first 1 week is normal. And beyond 1 week, then we need to keep a watch for PVL. In grade 2, we have tiny cystic lesions, few cystic lesions which start appearing in the frontoparietal region. In grade 3, we see extensive periventricular lesions. And in grade 4, the lesions extend into the subcortical region within the deep white matter. And how is grading of periventricular white matter done? So we compare with choroid plexus. In grade 0, the echogenicity is normal, that it is less brighter compared to choroid plexus. In grade 1, it is almost as bright as choroid plexus. And in grade 2, it is much more brighter when compared to the choroid plexus. So identify the view and what is shown here. So this is the coronal plane. We see that there is periventricular white matter, echogenicity is seen. So this falls under grade 1. So again, identify the views and the finding. So in this, we are able to see some cysts which are present in the frontoparietal region. So here they are seen just above the lateral ventricles in the coronal view, superior and lateral to the lateral ventricles. And in the sagittal view, it is seen superior and posterior to the lateral ventricles. So these frontoparietal cysts fall under grade 2 PVL. So this is grade 3 PVL. In this, the cystic lesions are seen extending into the periventricular region. So grade 4 we have already discussed. Coming to the next question. So identify the view and what is calculated here and what is the formula and what are the normal limits. So this is the midline sagittal view. After in the midline sagittal view, we place color Doppler, then we'll be able to trace the anterior cerebral artery. And the point where there is the anterior cerebral artery, there is a straightening of anterior cerebral artery, we'll place a pulse wave Doppler here. And we calculate the peak systolic velocity and the end diastolic velocity. So resistive index is calculated by formula of peak systolic velocity minus end diastolic velocity by peak systolic velocity. So the normal limits of RI in term babies are around 0.75 plus or minus 0.08. And what are the causes for increased and decreased RI? So anything, the increased RI is because of PDA, hydrocephalus, and hypocarbia, whereas reduced RI is because of asphyxia, shock, sepsis. So anything below 0.6 or 0.55 is taken as decreased RI. So this is low RI in asphyxia. Here we can see that the end diastolic velocity is increasing. And here we can see the reversal of diastolic flow. So coming to the next one, what is the diagnosis here? The clinical presentation of this condition. So the diagnosis here is vein of Galen malformation, which is better known as the heavy malformation of prosencephalic vein. So it can present either in antenatally or postnatally with high output cardiac failure. So the clinical signs which are seen are tachycardia, bounding pulses, hepatomegaly, shock, and the most important clinical sign is bruit in the cranial region. Management, if the high output cardiac failure is under control with medical management, we can wait for embolization till at least 6 months for the cavernous sinus to mature. But in case if it is not being able to control with the medical management, in such cases, we can try embolization little earlier with coils or cyanacrylate. So coming to the next question, what is the abnormality here and what is the significance? So here we can see some cystic structures which are present just lateral to the ventricles. So these are the conatal cysts. But we can also consider differentials like PVL in early stages or subependymal cysts. But mostly conatal cysts are also normal findings. They do not have much significance and they usually resolve within the first few months of life. They are formed because of focal fusion of the lateral ventricular walls. Okay, this ends my presentation. Thank you for joining everyone.